Please listen carefully.
Hello and welcome to Gas Gas Gas. This is the best podcast for the FRCA primary exam. Our goal is to fill your brain with all this highly useful information. You might be in the gym right now, commuting, or ironing your scrubs. Regardless, the revision is eventually going to end, but for now, expect facts, concepts, model answers, and the odd tangent. Make sure to check out gasgasgas.uk. The show notes there's loads more detail. Make sure to like and subscribe. Anyway, buckle up, get ready for your mind to be bent into a new shape, and let's get on with the show. Hello everyone, this is James at Gas Gas Gas. Welcome to another episode of the Primary FRCA podcast. We're going to smash through Methadone today. I hope you're finding this podcast useful and it is fitting into your day. If you reckon I need to improve things, change things, just drop a comment or send me an email. I'm super game to receive it. Anyway, getting on with the show. Methadone. Methadone is a synthetic opioid, i.e. we've invented it as humans on planet Earth. It's a derivative of piperidine, much like fentanyl, alfentanil, etc. It comes as a clear, colourless liquid if it's IV, or in the UK as an oral preparation with colouring, classically green, but I think it used to be brown as well. Now, as to why it's coloured, don't really know, but I'm guessing it's obvious if a bright green liquid has been drunk, as opposed to maybe being squirreled away for later. Not that I'm jumping to any conclusions about anything in particular there. It can be given oral, subcutaneously, intramuscularly, intravenously, or rectally, depending on your inclinations. And it's important to note that it is an enantiomeric mix, so you've got L-methadone and R-methadone, and it's the R-methadone that is the active molecule. Before we dip into all the pharmacokinetics, I'm yet again reminding you how opiates work, because that's a likely question to come up in a multitude of manners, and clearly is something we should just know. So opiate receptors are G-protein coupled receptors. There's mu, delta, and kappa, and a load of other ones probably, but mu, delta, and kappa are important, and they are coupled to a GI, i.e. an inhibitory subunit that you will find on the other side of your cell membrane. Remembering that a G-protein coupled receptor is a serpiginous transmembrane protein with 7 transmembrane domains and a bunch of secondary messenger molecules on the internal side that are released on agonism, where they go and potter off and trigger intracellular pathways that yield to changes in things. Things being, vascular endothelium, bronchodilation, etc., etc., etc. What happens when a opiate receptor is agonized? You trigger potassium channel opening, i.e. more potassium is getting inside your neuron. You cause closure of calcium channels, i.e. less calcium is getting inside your neuron. Calcium triggers the release of synaptic vesicles, and you inhibit adenyl cyclase, which leads to less cyclic AMP, which also influences the activity of the neuron. But thinking about methadone, as with tramadol, it doesn't just mess with mu, kappa, etc., etc. receptors. Methadone potters along and binds to other receptors as well. So it is an NMDA receptor antagonist, so it influences the activity of neurons, much like ketamine does. Methadone also has serotonin activity, binding to 5-HT2A, remembering that there's loads of serotonin receptors. Why is it important to know that methadone doesn't just work on those things? Well, lots of medicines actually probably have a little bit of covert serotonin activity, and a number of anaesthetic agents we use also have some serotonin activity, or we perhaps may neglect to remember that fentanyl, for example, and alfentanil, and sometimes a bit of morphine, all can influence your serotonin activity. The summative effects of this could end up being serotonin syndrome if you were unfortunate. And let's just all recall that serotonin syndrome, you would find yourself with a classically agitated, fairly flushed, red, tremulous patient. You might have a tachycardia and a hypertension. They will go on to get more and more agitated, develop hyperreflexia, can get ankle myoclonus that can be quite prominent. They can be bouncing around in the bed. And if they're really unfortunate, opisthotonus, i.e. myoclonic eyeballs, where they're bouncing around all over the place. You're going to see it classically with overdose of serotonergic agents. Anyway, brief sojourn to intensive care medicine there. Let's just come back to methadone. So what do we use methadone for? So in the UK particularly, and I imagine in other places around the world, it is used to manage opiate addiction, i.e. those people who have been unfortunate enough to develop addictions to either, heroin, either injected or smoked, or those who've managed to become addicted to over-the-counter, no, not over-the-counter, unless it's a drug dealer's counter perhaps, opiates where they've managed to get their hands on bottles of Oromorph or oxycodone through indirect routes, and actually they found themselves, oh, I'm accidentally addicted to opiates. It's used sometimes in pain control in the perioperative setting. It might have a bigger role in this than it currently does in the future. It has been used, for example, in children having spinal surgery for like correction of scoliosis, kyphosis, and it is growing in its use in managing cancer-related pain, sort of palliative hospice type settings. How would you go about dosing methadone? Well, there are two subject areas here, or maybe three subject areas in fact. Dosing methadone for those who are trying to get off heroin is an entirely separate topic and not one I'm going to cover, but sounds quite tricksy in some regards and needs to be titrated in the community by drug and alcohol specialists. For cancer-related pain, one paper provided guidance saying 2.5 milligrams 3 times a day, twice a day. You can increase the dose every 5 to 7 days. You could consider starting on 5 milligrams a day if they are already using opiates. IV dosing for methadone, 0.1 to 0.2 milligrams per kilo, 6 to 8 hourly. And it's important to think about morphine equivalents, and 1 milligram of methadone is approximately equivalent to 10 milligrams of morphine. Now, why do I say approximately? Well, nothing is hard and fast, and actually if you are on frequent methadone, the level of activity is altered, and that is because you alter the amount you can absorb, i.e. the oral bioavailability. What's the pKa of methadone, you so astutely ask? 9.2, in fact. And it's 1% unionized. And you say, well, 1% unionized? I was under the impression that things need to be, fairly unionized for it to be of any use. And methadone is very fat soluble, in fact. It's got a volume of distribution of 1 to 8 litres per kilo, and the quoted half-life 2 to 65 hours. But in prolonged use, you're going to fill up that person's fat stores, and actually you probably have a reasonably prolonged effect of methadone. Onset time is about 30 minutes and it lasts for about 4 to 6 hours. We're talking about this acute dosing as opposed to someone who's on it all day every day, because actually they take methadone once a day. What's the side effect profile of methadone? Well, it can cause QT prolongation, especially in really high doses. So if you've got a patient in front of you, you've been called to A&E and they've had a methadone overdose, don't forget the ECG. And also, in this patient population, you don't want to mix other drugs that cause QT prolongation with them, do you? Because you'd be daft, wouldn't you? So reaching for haloperidol and managing their agitation afterwards might be an error. It can cause orthostatic hypotension as well from a cardiovascular perspective. Naturally, you're going to have the opiate respiratory side effects of it being an antitussive and a respiratory depressant. CNS-wise, you're going to expect opiate effects, so it can cause drowsiness, euphoria, hallucination. If you were to give it to an elderly population, you're probably going to trigger more delirium, and you get the small pupils of Edinger-Westphal nucleus alterations. GI effects, again, opiate, dry mouth, nausea, vomiting, constipation. But interestingly, with methadone, it can also cause hypoglycemia. This is more prominent in situations with a cancer patient and those who are having a rapid up titration of methadone in the community, although it is pretty rare. It can cause urinary retention, as can most opiates, and it's also been noted to potentially cause some adrenal insufficiency in some patients as well. So it's not without its complications. It would be important just to touch base here. We're all thinking, oh, that sounds like it's got quite a rough side effect profile when we're considering using it as a way to wean people off opiates. It's not the only option. You can also use buprenorphine patches, which have perhaps a different side effect profile, which we'll find out at a later date when we cover buprenorphine. Those are the pharmacodynamics of methadone. Now, what about the pharmacokinetics of methadone, i.e. what the body does to the drug? So we're going to give some oral methadone. It's got an oral bioavailability of about 70 to 80%. It is highly protein bound to chiefly alpha-1 glycoprotein, 60 to 90% protein binding. Now, with extended use from a metabolism perspective, you'll creep up into those higher half times of 55 hours. The range is 15 to 55 hours. It is metabolized by our dear friends CYP3A4 and CYP2D6. Remembering that CYP2D6, 10% of the population don't do a terribly good job of having functional CYP2D6. They're hypo-responders, under-responders, whatever you want to call them. They will have an extended effect of methadone. It is urinarily and fecally cleared, and you can reverse its opiate effects with naloxone. That's pretty much it for methadone, guys. So, in summary, methadone is a opiate receptor agonist, as well as an NMDA receptor antagonist, and it has serotonergic properties. Its chief uses are for managing opiate addiction. However, it has a growing role in managing pain in the palliative setting, and perhaps has a role in the future for managing pain in the acute setting. Check out, if you're interested, the papers that are referenced in the show notes for more information about methadone. Anywho, thanks for listening. Have a nice weekend. Cheerio and goodbye. Thanks for listening, guys. I hope you found it useful, but if you found it awful, do let me know. Please like and subscribe, register with whichever podcast platform you find yourself using, and leave a comment if you think I need to square something away. I just want to make sure that you guys know that every day you are getting better at this. There is a bucket of content to try and consume, and it is like drinking from a fire hose. Take it day by day, don't overcook yourself, don't freak out, and keep studying.